Assalamu alaikum wa rahmatullahi wa barakatuh. Hello my daughters and sons. Today we will discuss anti-Parkinsonian drugs. What's Parkinsonism and what's the cause of Parkinsonism and how can I treat the case of Parkinsonism? Parkinsonism is disease due to lesion of basal ganglia characterized by static tremors, muscle rigidity, mask face, and stifling gait. The etiology of Parkinsonism may be primary or unknown due to reduction of the activity of inhibitory dopaminergic neurons in the substantia nigra and the corpus striatum part of basal ganglia that are responsible of motor activity. Or the cause may be secondary to infection at viral encephalitis or vascular as multiple small vascular disease or drug. When the Parkinsonism is due to drug called iatrogenic Parkinsonism. These drugs include phenothiazine, haloperidol, which act as dopaminergic antagonists, reserpine, which deplete dopamine storage, and methyl dopa, which decrease senses of dopamine. So any drug that antagonize dopamine in CNS, especially in basal ganglia, may precipitate Parkinsonism. These drugs act by different mechanisms. They may act as receptor antagonist, or they act on storage, they deplete dopamine storage, or they inhibit senses of dopamine. Parkinsonism is caused by either increased acetylcholine or decreased dopamine. There is a balance between acetylcholine and dopamine in basal ganglia. This balance is disturbed either by increased acetylcholine or decreased dopamine. Parkinsonism will occur. So the treatment include anticholinergic drugs and dopaminergic drugs. Anticholinergic drugs as natural belladonna, synthetic atropine substitute, antihistaminic, first generation antihistaminic, which has atropine-like effect, as diphenhydramine. Dopaminergic drugs, which include L-dopa, neuronal dopamine, BROMOCRYPTINE, and pergolide, which act as dopamine agonists. AMANTADINE, the antiviral drug, but it increases dopamine release and it decreases its uptake. SELEGILINE or DEPRENYLE, which is MAO type B inhibitor. That is MAO or monoamine oxidase type B, which is responsible for dopamine breakdown. So when I use SELEGILINE, I decrease dopamine breakdown. Tolcapone and entacapone, which act as COMT inhibitor. Catecholamine also methyl transferase inhibitor. This enzyme is responsible for degeneration or breakdown of all catecholamines, including dopamine. This diagram shows the drugs that used in treatment of Parkinsonism. It includes L-dopa, which increase senses of dopamine, and the dopaminergic receptor agonist, which activate dopamine receptor. SELEGILINE inhibits MAO type B, monoamine oxidase type B, which is responsible for generation of dopamine, and muscarinic receptor blockers, which decrease the activity of cholinergic neurons. Anticholinergic drugs. Natural belladonna alkaloids such as atropine and hyoscine. Synthetic atropine substitute, which is specific for treatment of Parkinsonism as trihexyphenidyl and benzotropine. They decrease tremors and rigidity, but they cause cerebral stimulation and may cause sedation. Antihistaminic, which has atropine-like action, first generation antihistaminic as diphenhydramine, dimenhydrinate. They decrease rigidity and tremors, but they may cause sedation. The second line of treatment of Parkinsonism is dopaminergic drugs. First, L-Dopa. 1 to 5% of L-Dopa can pass blood-brain barrier and is changed to dopamine, which stimulates dopaminergic receptor type 2. 95% of L-Dopa undergo peripheral decarboxylation to dopamine, and this peripheral dopamine can't pass blood-brain barrier. This is a huge amount and huge percentage of L-Dopa which undergo peripheral decarboxylation and they can't pass blood-brain barrier. And so I use large dose from 3 to 8 grams per day to overcome this peripheral decarboxylation. But this large dose and by its peripheral decarboxylation to dopamine may cause serious side effects. So I use some drugs that act as decarboxylase inhibitors, and these drugs are carbidopa and benzeracid. They are decarboxylase inhibitors in tissue which don't pass blood-brain barrier. So I combine L-Dopa with these drugs which act as decarboxylase inhibitors to inhibit peripheral decarboxylation of L-Dopa, and this will reduce this large dose due to reduction of peripheral decarboxylation. Carbidopa plus L-Dopa called Sinemet, and benzeracid plus L-Dopa called Madobar. This good combination due to reduction of peripheral decarboxylation of dopamine. Drug interaction of L-Dopa is very important. Pyridoxine, vitamin B6, to act as coenzyme feed for the peripheral decarboxylation. So increase the peripheral breakdown of L-Dopa. So it is bad combination of pyridoxine of vitamin B6 with L-Dopa, as it increase its peripheral breakdown, so increase the peripheral side effect of L-Dopa. Reserpine and chlorobromazine, which are reserpine is depleter of dopamine, chlorobromazine is D2 inhibitor, so they decrease the potency of L-Dopa. MAO inhibitor, monoamine oxidase inhibitors, increase dopamine hypertensive crisis caused by enhanced catecholamine production, as they inhibit dopamine breakdown and inhibit also all catecholamines. So they cause prolongation of action of catecholamines, and this cause hypertensive crisis. Side effect of L-Dopa: hallucination and brown urine due to its metabolites, nausea and vomiting as it stimulates chemoreceptor trigger zone, tachycardia and postural hypotension as act on dopaminergic receptor peripherally, and these dopaminergic receptors cause vasodilation of blood vessels, and this causes reflex tachycardia. Involuntary movement, chorea, dyskinesia, which is related to the dose, stimulates sexual activity, chronic effect, wear off and on off, wear off due to rapid degeneration or more degeneration of L-Dopa, on off effect due to short plasma half-life of L-Dopa. So I can't use L-DOPA in case of glaucoma as it increases intraocular pressure. I can't use it in cardiac patient. It causes tachycardia, and this may cause or induce arrhythmia, and they may induce anginal attack. Peptic ulcer and psychotic patient, as it increase or act as D2 agonist. When I stimulate D2, I cause psychosis, I cause cerebral stimulation, and I increase secretion of HCl. I increase secretion of HCl, and this, so it is contraindicated in peptic ulcer. And I stimulate chemoreceptor trigger zone, which causes nausea and vomiting, and this is dangerous in patients with peptic ulcer. History of melanoma. L-DOPA is a precursor of skin melanin, so I can't use it in patients with history of melanoma. Tolcapone and entacapone, they are COMT inhibitor. What's a COMT? COMT is catecholamine orthomethyl transferase. The enzyme is responsible for breakdown of catecholamines, including dopamine. Why I inhibit this enzyme? I prolong the action of dopamine and decrease formation of 3-oxymethyl-DOPA, this metabolite of dopamine, which compete with L-DOPA for active uptake in CNS. So I prolong the action of dopamine and inhibit the formation of this metabolite, which compete with L-DOPA for active uptake. I use tolcapone with L-DOPA carbidopa combination. This combination decrease peripheral decarboxylation of L-DOPA with tolcapone, which decrease breakdown of dopamine and L-DOPA. But when I prolong the action of L-DOPA, I may increase the side effect of L-DOPA. So I use tolcapone with caution. And this tolcapone may cause fulminating hepatic necrosis. Ergolines, which include bromocriptine, glyceride, and pergolates. They are ergo derivatives with dopaminergic activity. Bromocriptine or PARLODEL, the ergo derivative, which act as dopamine D2 agonist to stimulate dopaminergic receptor in basal ganglia. And so I use it in treatment of Parkinsonism. When I stimulate D2, I inhibit prolactin secretion, and so I inhibit lactation. I use this drug in treatment of amenorrhea galacturea syndrome, which may cause anovulation. So this drug, by inhibition of prolactin secretion, may stimulate ovulation. Treatment of pituitary tumors with hyperprolactinemia or acromegaly, as this drug decreases growth hormone secretion. So bromocriptine, it is ergo derivative that have dopamine D2 agonist activity. It's used in treatment of Parkinsonism. It inhibits lactation, so I use this drug for inhibition of lactation in lactating female, and the treatment of amenorrhea galacturea syndrome, treatment of infertility due to anovulation, as this drug by inhibition of prolactin may induce ovulation. Treatment of pituitary tumors which associated with hyperprolactinemia or acromegaly, as this drug decreases growth hormone secretion. What's the side effect of bromocriptine? It causes nausea and vomiting due to stimulation of chemoreceptor trigger zone as any drug that act as D2 agonist. Any drug that act as D2 agonist will stimulate chemoreceptor trigger zone, which cause nausea and vomiting, and inhibit prolactin secretion. This is very good in treatment of amenorrhea galactorrhea syndrome. But any drug that act as D2 agonist cause more excitability of cerebral cortex, which is very dangerous in psychiatric patients, and this is one of the side effects. So any drug that act in D2 receptor and it act as an agonist has two use and two side effects. To use, it treat Parkinsonism, and it used to stop lactation and inhibit prolactin secretion, used in treatment of amenorrhea galactorrhea syndrome and gynecomastia in male. But it caused two side effects, nausea and vomiting, and stimulate cerebral cortex, which may cause psychosis. It causes bromocriptine, cause postural hypotension, which is a first dose phenomena, and so care with antihypertensive drug. This postural hypotension may be due to vasodilation of peripheral blood vessels. Contraindication: psychiatric illness, as it stimulates cerebral cortex; peptic ulcer, as it stimulates chemoreceptor trigger zone and stimulate HCl secretion; history of myocardial infarction may be due to reflex tachycardia; peripheral vascular disease, and this is a wonder, as it may cause peripheral vascular dilatation, but it is ergo derivatives, and this ergot alkaloid may cause direct vasospasm of blood vessels, and this is very dangerous in peripheral vascular disease. Amantadine. Amantadine is antiviral drug used in the treatment of influenza, but it has anti-Parkinsonian activity. It reduces rigidity and tremors. The mechanism of action of amantadine: it releases endogenous dopamine and prevents its uptake, and it has slight anticholinergic effects. Adverse effects of amantadine include ankle edema. Ankle edema is a side effect of amantadine and another drug. What is the other drug that causes ankle edema? This is a question for you. It may cause restlessness, hallucination, insomnia, and agitation, cause postural hypotension. These side effects, restlessness, hallucination, insomnia, and agitation, may be due to stimulation of cerebral cortex. Postural hypotension may be due peripheral vasodilatation. Dry mouth and urine retention due to its slight anticholinergic effect. Wearing off effect develop more rapidly with amantadine, as it releases endogenous dopamine and prevent its uptake. This dopamine will face breakdown by comtandemao, and this may cause more generation of dopamine. It has two sides. It increases dopamine at its site of action, but it leaves dopamine to face its breakdown. Wearing off effect develop more rapidly wearing off effect due to rapid degeneration of dopamine. Contraindication: it is contraindicated in case of heart failure and in patients with history of seizure, as it increase cerebral activity, and I fear from patient with heart failure, I fear from tachycardia, I fear from this edema, I fear from salt and water retention, so I use amantadine with caution. Selegiline or DEPRENYLE, it is MAO type B, which metabolizes dopamine. This is specific for dopamine. It's used with L-dopa to improve wearing off due to rapid degeneration of dopamine. This degeneration occurs by COMT and MAO type B. When I use MAO inhibitor type B, I reduce this metabolism and so I improve wearing off. Selegiline not used alone, but in combination with the two agonists. I use it with L-dopa to improve wearing off. Adverse effect of selegiline: it is dose related. If DEPRENYLE is administered at high dose, the drug loses its selectivity. It is selective for dopamine, but when I use it in high dose, this selectivity will be lost, and the patient is at high risk for severe hypertension, as it inhibits degeneration or metabolism of all catecholamines, including noradrenaline and adrenaline. Pramipexole and robrinol, they are non-ergot dopaminergic agonists. So the drug used in treatment of dopamine include anticholinergic drugs, atropine and hyoscine. Atropine substitute, which is specific for basal ganglia, which include trihexyphenidyl and benztropine, and antihistaminic, which has atropine-like effect, first generation antihistaminic, as dimenhydrinate and diphenhydramine. I use dopaminergic drug in treatment of Parkinsonism. These dopaminergic drugs may act as a source of dopamine as L-dopa, or dopaminergic receptor agonists, which may be ergot derivative or non-ergot derivative. Ergot derivative as BROMOCRYPTINE, non-ergot derivatives as pramipexole and robrinol. Or I inhibit degeneration of dopamine. I inhibit this degeneration by use of MAO type B inhibitor, which is selegiline, or I inhibit COMT enzyme, catecholamine also methyltransferase, which include tolcapone and entacapone. What's the drug contraindicated in Parkinson's? Drug contraindicated in Parkinsonism are the drugs that cause increase in acetylcholine synthesis secretion, or drugs that act on muscarinic receptor CNS, which act as parasympathomimetics, or any drug that affect the dopamine receptor, affect dopamine stores, or affect dopamine senses, which include dopamine blockers as domperidone and haloperidol, dopamine depleters, reserpine, and dopamine senses inhibitors as alpha-methyl-dopa. So the drug contraindicated in Parkinsonism include parasympathomimetic, dopamine blockers as domperidone and haloperidol, dopamine depleters as reserpine and alpha methyl dopa, which inhibit dopamine synthesis. Thank you.